you leave, or it will be emailed to you. So if you have any questions and stuff, they'll be able to answer it for you. Our last speaker today is hygiene. We found Jan a few years ago, and ever since she started working with us, our hygiene department is doing 10 times better in every office that she has touched. She is a leader in the hygiene industry. She works with over 3,500 offices. She is no slouch, so I'm going to let her talk to you really quickly about what she does and how her services actually have changed our company as a whole. And if you have questions, you can ask her when it's done. All right?
I'm going to hook this up for a minute. Does it have a hook?
Yeah, you can hook it up right here.
Okay, here. It's always a little personal, but we'll handle it.
That's okay.
Okay. All right. Yes, thank you for hanging in there. I know we've had an amazing 2 days, and I learned a lot. Always learn a lot when I get to here, and I've really seriously enjoyed spending time with quite a few of you in the 2 days. And as soon as you found out I was a hygienist, am I a solo hygienist here? Do we have any hygienists? I was told not, but if you are, you might be hiding. So as soon as anybody that I had an opportunity to engage in conversation, and they found I was a hygienist and that I was going to actually be talking, I loved your questions. And so what I'm going to try to do is weave some of those in this last quick, I'll try to make it a short hour, okay? Because the questions probably are all very similar to what I've been getting. I've been a hygienist for over 35 years, and I fell in love with hygiene, believe it or not. However, prior to falling in love with it, I think I experienced just about every frustration and every challenge that your hygienists have. And I considered real estate many times. And then I decided it was just way too soon. It was like my first year as a hygienist. And decided that I needed to dig in and see if I can figure something out here. And so I became an entrepreneur. But what I first did is I learned a lot. And I learned a lot about perio. I had amazing mentors in perio, and I became a non-surgical periodontal hygienist. And that's what just took me to a whole nother level in, and now I'm going to admit my age, but it was the early 80s, and a management consultant happened to recognize in Chicago what I was doing that was different. And what I was doing was I was lost in my clinical world, seriously. I didn't pay attention to the business model. I didn't pay attention to how much money I had to produce. Typical hygienist, right? Okay, but guess what happened? The profits came. The production came. And I still didn't pay attention because I was lost in my clinical world. But a management consultant was really smart, and she noticed the difference in the profitability. She noticed the difference in growth, and she said, "What are you doing?" She sat in the chair, and she said, "Why isn't the rest of dentistry doing that?" And so that's how my career took off. She wanted me to start teaching, and I said no, because that's not what I was put on this earth for at that moment in my life. And however, with a lot of, I'm going to say, convincing, she really convinced me that that was something that I could help change lives. And so 35, I'm fast forwarding here because we've got a lot of time, and what I want to do is give you some answers. But it started my career as a hygiene trainer and consultant, and 35 years later, we've trained over 3,500 practices, hands-on. Okay, because that's going to be, that's it. It's got to be hands-on. There's got to be, just like when you learn a new technique, a new procedure, you want to dig in and actually see how can we do this differently. So to fast forward, what we're gonna do is talk about some of the questions that I got, okay? Because I did get a lot of questions from many of you, and I tried to answer some of them, but it was pretty interesting, because I'm gonna set this right here. Many of them started off with, it just started to become a little redundant, and many of the questions started off with things like, how do I get my hygienist to fill in the blank? How do I get the profits in hygiene? How do this is one that I want to give you all a compliment that's here in this room. But literally, seriously, I've been speaking and presenting for over 35 years at so many amazing meetings, and I really feel like I've met some of the smartest people in dentistry. Seriously, because dentistry is hard and it's physical. And for those of you that have really looked at the critical aspect of becoming a business person and an entrepreneur, and realizing that our bodies are not really designed to be in this position forever and ever and ever, and that the smarter that you look and think outside of the box and become business owners, I'm serious, because I was lost in a kind of a boutique, high-end world for a while. Did a lot of work at the Las Vegas Institute with practices that were, selling $20, $30, $40, $60,000 cases. And as soon as we started hearing about the DSO world and multiple practices, we went through, the same probably concerns. But as soon as I started working with some pretty amazing practices that have multiple practices, I learned quickly that it didn't take away from the quality, ever. And it just became smart business owners that recognized if it's been done, okay, if it's been done, it can be repeated, correct? So that's what we're gonna go through, is trying to answer some of those questions of, how do I get my hygienist to blank, fill in the blank, right? And the first one is achieve amazing profits. So there's going to be some secrets here, and that's one of the reasons why, I wanted to know, do we have any hygienists in the room? I can talk about hygienists easier when they're not here, but I don't want to talk about them because I've worked with and trained some pretty amazing hygienists. But most of all, most of our hygienists, you've already figured out, they don't want to talk about profit, do they? Do you have hygienists that like to talk about their production? Good. Okay, well then you've trained them well, okay? Because the ones that are willing to talk about it and understand it and are willing to accept that I'm a producer, that's a good thing, and that means that you've made some headway there. So we already talked about the clinical hands-on training. You do have these pie charts in your manual. And I don't know if some of you have already seen these, but what I'd love for you to do is just take a look at them if you haven't already. I know you've been real busy listening and learning a lot, but it's pretty self-explanatory. This is our Dental Force and JP Institute clinical model, okay? And what you should be doing is taking a look at this model and determining where you're at. You see there's not numbers attached to it, but the numbers are logical, okay? So the more that you have a blended service in your hygiene department, you're gonna achieve the profits, you're gonna achieve the production, and you're gonna achieve the growth. There's a lot of other major advantages that will come along with achieving this business model, because it's all also gonna show up in your strength of your retention, as well as your internal marketing. So to just give you the brief explanation, the first one, that is hopefully none of you are living in that world, okay? And if you are, actually it's an okay thing too, because that means you have huge possibility to convert that. And so for those of you that have been busy investing in new businesses, new practices, and I talked to one of the doctors here, I think he had to leave, and his concern was, he buys practices that are old practices with And he didn't use the word old, I thought that was nice. He said experienced hygienists that have been there a long time and they don't want to change. And they're doing a lot of pro fees. And I said, well, that's not a problem. It's actually an amazing opportunity because you can change that and you're going to get an increase anyway. I just had a phone call last week from one of our practices, and within, probably took them about 3 to 4 months, they started seeing a change in $30,000 a month, increased to $40,000, and then they maintained at about $50,000 a month increase in just their hygiene department. And so if that kind of opportunity is available, then that's a good plan, is to find a practice that's really not achieved their huge profitability, and then we can, you can help them make that change. So the first one is when you're actually working in a very, very traditional, and I'm gonna even now at this point say the word old school, because what percentage of your patients are just pro fees? Seriously. And then the second model is probably the one that we see the most in dentistry, unfortunately. And this model is still not a good model. But again, the positive aspect is if you are living in number 2, that means you have that much more profitability available to you, okay? Because the 76% is the pro fee, the 4910 is your green, that's your perio maintenance, and on your actual root planing combination between 4341 and 4342, which is your root planing, or we call it periodontal therapy. Oftentimes we see that about 14%, and I'm going to say across the board. And once we start shifting and doing our training and working with our entire team, as well as the clinical team, especially the hygienists, but the entire team, the doctors included, we start to see the shift in the numbers. Okay, and so what I am going to do is going to go through these slides pretty quick, so that instead of me being the person that says, oh yeah, you need to produce more, you need to do a more blended approach to treatment, you need to offer a higher level of services with therapy, easier said than done, correct? So we're going to go through the rest of the slides to see if I can at least give you some pearls to what's available to you, and then how to do that. And that's what we do as trainers in our dental force practices as well. So the third pie chart, or the fourth pie chart there, you can see that would be optimal. And optimal is where we really have as much as maybe 32%. Sometimes we see that go higher. We have so many practices, our dental force practices. I was blown away when I started working with them because of the level of new patients. And it just was mind-boggling to me. And the more that I spend time in the practices, it became easier and easier to make these transformations, because the attitudes in these practices are pretty amazing. And the new patient is where you're going to get the largest percentage of your perio, but it's not the only place. As a matter of fact, that's probably the biggest missed opportunity. Okay, your new patients should be a no-brainer. That we now know, we just all know too much now. We don't ignore perio. That's not what we do, and your hygienists don't do it. It's usually the existing patient, the patient that's a patient of record, and that's where your perio is going to be hiding. Okay, so the 51% is where if you define and really redefine what a preventive prophy is versus a supportive or perio maintenance. And therapeutic, this fourth pie chart is what should be living in your practices. Okay, so I do want to ask you a question. I know it's the end of 2 days. So what I learned from Tina is you have to pick on someone. But I just help me out. You don't have to answer. If somebody's just wants to, but so your hygienist, if you were to ask your hygienist this question, I want you to just think of your practice. And if you went back to the practice and you said, what percentage of the time are you really only doing a preventive pro fee? What do you think your hygienist would say? Anybody? Do I have to pick on you, Michael? Because I know you're in the front of the room.
I'm available too if you've done.
What do you think they'd say? Like, oh, here's some key words here.
So what does that mean for me? I actually don't understand.
Well, okay, well then you know what, and then you would have to define it. Okay, so the CDT or the insurance definition, it's not even insurance, but if you looked at the American Academy of Periodontology, preventive procedure is scaling above the gum line and into a healthy sulcus and a cosmetic polish. Scaling above the gum line into a healthy sulcus with no attachment loss and a cosmetic polish. Okay, what percentage of the time do you think you're hygienic? Oh, I have a volunteer. Yes. Okay, 60.
When they only say above the gum line.
Yeah.
That's what they ask.
Yeah. So she says 60%.
10%.
Okay.
Yeah.
Now we're getting somewhere here because I have the amazing opportunity. I talk to hygienists all the time, and sometimes they're a room of 50 and sometimes 500. And literally, I usually get rolling eyeballs. I mean, because I can see them, right? And they're like, it's almost like a silly question. Like, why would you even ask me that question? Because why? Because they hardly ever do that. And they would even say that, like, well, almost like excuse me. I hardly ever, and then we might even get that kind of thing, ever do just a preventive pro fee. And I get it. And that is the truth. Now, some of you have maybe found hygienists that have figured it out and they've gone beyond that, but that's where once you really start redefining what true preventive is, true disease, you're gonna go to another level. But it's easier said than done. But this is your checklist. And that means that it starts with what? Amazing profits in any dental practice, whether it's restorative practice, cosmetic, hygiene, it starts with a clear, concise diagnosis. And if the diagnosis isn't there, then your treatment plan's not gonna be there. If the treatment plan's not there, you're not gonna get case acceptance and it's not gonna show up on the schedule. So that's the simplicity of all of this. So it has to start with an effective diagnosis. So in a traditional practice, this is where you don't want to be, and especially because we're probably in a time in dentistry where insurance has become the least predictable as ever. The PPOs do not give us fees that are equal to the value and covering the overhead that we all have to handle. So this is where we really have to define what a true pro fee is. Because if you have any PPOs in your practice whatsoever, and you're getting reimbursed for bottom dollar, and your hygienists are doing more than a pro fee, they're probably great hygienists. Okay, I'm not trying to make them wrong or bad, because I'm sure that many of you love your hygienists. And there's a reason that they do that. And if they could do it different or better or another way, they'd already be doing it, right? They'd already be doing it. So if you look at the traditional versus the comprehensive, we still, one of the stipulations of being able to work with dental floorists I loved is like, yeah, of course we need an hour. Because it's quality. And one of the most important things that I saved till last, but I know the big question. It's in your manual, it's gonna come up last, but it's probably the biggest question. Is once we start asking our hygienists to do all these things differently and better, what's their biggest bugaboo? Or the word that you guys, the O word. What's their biggest overwhelm? That's it. Time. Okay. And our hygienists that figure it out, they have more time to breathe. And they might feel initially in a training, they might have this initial wave of overwhelm because of training. And then after that, the relief kicks in. So this is the blended approach that you need to have. And then to me, probably the biggest value besides, getting the profits that you not only need but deserve in hygiene is once you have that blended schedule and your hygienist really has figured this out with training, they have more time to communicate restorative. They have more time to educate restorative procedures and peripherals and whitening and fluorides and sealants and cosmetics and aesthetics because they have more time and they're not in this position putting the pedal to the metal trying to treat an infection with a preventive procedure, because when we do that we don't have time. So when we start to figure it out and we get it all pulled together, then you're going to get an increase in your restorative as well. And you should be getting an increase in your restorative. So if these things aren't falling into place, then just know it can change. Yeah. Well, thank you. I didn't have a place. Where do you think? Right there? Okay, good. So, let's go back. The metrics, these are important. So I know that you have them in your manual, so I'm not going to really read them to you. But the one that we've talked about more than once is the hygienist really needs to be producing 3 times their salary. Okay, so I am going to encourage you, though, the last thing you want to do is to go back and give them this list. Why? Will they like it? What would they say if you gave them that list? They have to work faster. And they will want to know, I promise you, it'll only be, unless we give them tools, and unless we tell them how to do it differently. Not only how, why. Why. And their why is going to be different than your why. Because they're not, unless they're a business owner with you. Because their why is based in what? What's their biggest why? Why would I do things differently? Anybody want to give that one a shot? It always, I've even heard it, I've heard it repeatedly. I will make this change. It's like a negotiation. I'll do this. But I have to know without a doubt that it's in the best interest of the patient. And that this isn't about money. And it isn't about production. And it isn't about, it has to be that they know that the big why is it is about the patient. And the best part that where we're at in dentistry right now, it's a no-brainer. It's all about the patient. Everything that we do is about the patient. But the science is there, and they have to understand the science. And it starts with leadership, and that means the owners in this room, along with the doctors and your associate doctors. They need to become clinical leaders. And that's what's going to make the difference. So how do we get to training? How do we get to optimum? You definitely have to have a commitment to training, and that's what we do here. They don't hesitate. It's like get it in, get it done, and we get it done. And the teams have been interviewed and brought into these practices knowing they're going to get training. And I love it. because that means the resistance isn't there. You're gonna be part of this world, you're gonna learn, you're gonna grow, you're gonna get trained. It just can't be like through osmosis. And especially some of you, you have maybe 3, 4, 5, 6 hygienists, right? And some of them are really great, and they have great personalities, and they have great training, but are they on the same page? Were some of them trained a year ago and graduated, or some of them trained 5 years ago, 10 years ago, or 20? So we absolutely have to have a commitment to training, and then we have to have implementation. And the last thing that you can do is go back and tell your hygienists they need to do more therapy. They need to do more, they need to do more, use the laser more. Okay, you might have a laser, but it's sitting on a shelf because they're not confident in using it. They're not going to unless they're trained. So the action plan that we use is number one, I've already started on some of it, is we need to have a clearly defined philosophy and protocol that each team member supports. And so that's why our training programs that we work with, even though it's hygiene, everyone needs to be trained, because everyone needs to be on the same page. I'm going to tell you, I think I get just as many thank yous, gratitude from our dental assistants with our hygiene training than I get from anyone, because it changes their life. It changes their life in their own mouth, and it changes their life with their family, and it changes their life as a clinical assistant, becoming more valuable. And so we want to make sure that everybody's involved, and that the second one on there is that we've definitely established clear distinctions between preventive, supportive, and therapeutic procedures. And so that's where that blended, those pie charts, you have to continually, really, and the key is the diagnosis. And I'm going to tell you, I've tried teaching diagnosis without clinical hands-on, and it's almost impossible. It really is almost impossible. It's not unusual to go into a practice and maybe we'll have a small group of 12, maybe 15 team members. It's pretty eye-opening because we do screenings on the entire team. And we are shoemakers' children, we realize this, right? You guys all know what that means. Shoemakers' children don't have shoes. So we don't sit in the chair. And so what do we find? What world opens up when we do screenings on the entire team at different points? What percentage of them do you suppose have some type of perio, gingivitis or perio? Yeah, probably 60%. And it might, some of them may be early intervention all the way to, so gingivitis, but also of those, many of them have early airway, they're candidate for a sleep test. There's some of them that are high risk, and meaning they have family risk and they have high risk for heart disease or stroke or diabetes. And they also have perio. And so it's eye-opening for them, because that's some of the things that, and then the doctor hygiene exam we talked about, Dr. Evangelista, you touched on it, and of course we're not going to be able to teach it to you today because it's a process, but I'm telling you it's the key to as part of the action plan. Okay, so what has to take place and what Dr. Evangelista introduced me is, how do we get to 3 times? How do we get to 3 times or more? And I can promise you, in many of your practices, maybe you've already been doing this. So you don't need the big paradigm shift. But I can tell you just about every practice I go in, and we have some extremely high-end practices. Practices that have been working with oral systemic health for 10 years, doing saliva testing, sending their patients for blood tests. Really very high-end practices, and they still are looking for that next paradigm shift. Okay, so the paradigm shifts that we have to change our way of thinking, and it has to be based in what? Okay, before I hit this slide, I'm gonna keep asking you questions. So what our paradigm shifts as a clinician and as a hygienist, we're trained as scientists, correct? So the biggest paradigm shift that has to take place is in our belief in science. Because that's where our diagnosis comes in, that's where our protocols come in. Anytime that we make a change, we're gonna do things differently, it has to be evidence-based. It has to have science behind it. So there's quite a few, and probably the biggest one, and it was really refreshing. I apologize, I don't have your name, but I've talked to a few doctors here. And so I know that you're already totally on board, and you understand probably the biggest scientific change that's occurred. I've been a hygienist and loving doing what I do for over 35 years. I stopped counting. But I actually have had some of my biggest paradigm shifts as a clinician myself. I still get to practice locally in Carlsbad. I don't see 8 patients a day. I go in a couple times a month and I get to play. I get to use lasers and surgical air polish and do saliva testing and work with nutritionists and naturopaths and physicians and really understand how this connection of the oral systemic health and what we can do different in relationship to our patient's immune system and their total health. We have to collaborate. So the most recent, so for some of you that were trained in an era, some of you are owners and not clinicians, but for those of you that were, trained clinicians, doctors, dentists, many of you heard and have read about oral systemic health. We know that the health of the mouth is totally connected to the rest of the body. This is not a new concept, is it? It's been around since I saw it in my perio office. I worked in a periodontal practice in 1979, and what percentage of I know, he's laughing, I finally admitted I was really young. Okay, is what percentage of my patients that I saw at that time in dentistry in a perio office had heart disease or diabetes? More than half. And when I actually have an opportunity to talk to hygienists or periodontists, they're going to give you that same number. And the majority of them are on high levels of medication and have other inflammatory disease. And so we've known about this connection for a long time, haven't we? I mean, for just all of you, glance back to your first days in dental school when you had to do perio. It's like, ugh, didn't want to do it, right? And you look in the mouth, and you knew that when you had a mess, that there was something going on with that patient systemically. You didn't always know what it was, but it's kind of scary, isn't it? Sometimes when we would see the mouth and try to figure out, wow, what is happening? Well, the good news is there's a lot of research that's supporting that has been trying to figure this out. So this 2017 workshop, there's a workshop put on, that's a world workshop by the American Academy of Periodontology, and this is shifting our world and our legal and our ethical responsibility, and we've had some of our first lawsuits due to not looking at a patient, diagnosing disease, and having them understand the consequence of not treating that infection, that it may in some way affect their health because of the relationship and the correlation, that it actually has finally evolved. We have the science now that we're using the term causal. There's literally a causal relationship with heart disease, heart attacks, and stroke. And I know some of you may want to fight this or battle this one, and it's like, are you kidding me? Because in dentistry, across the board, it's taken about 20 years since we've had the research for us to get serious about it. So we really need to integrate that in our implementation. And guess what? You want case acceptance? You're gonna get it. Unless you're getting 90 to 95% case acceptance, then that means the opportunity of studying the oral. You don't want to shoot from the hip, and you don't want to make things up, and you don't want to just start telling your patients or they're going to have a heart attack, because it is way more serious than that, and it needs to be studied. So in our training, we do a lot of research. The team reads, the entire team reads. They read a lot of articles. Some of them love it, love it, and some of them don't love it. But they all read, and they all start to understand this information, and it's really critical. So there's a whole nother opportunity that's available. So we've known about this since 2000, but it's now time to integrate this into your treatment planning. And it is something that your patients will get it. As a matter of fact, this doesn't happen very often, but I talked to one of our patients at Delforce. He happened to find my name in one of the papers. And what was so cool is he was verifying. He said, well, I went to, and he was really excited. He knew he had a periodontal infection. He knew he needed laser treatment. And he said, I just have some questions. And it turned out that I checked back in with the team, and they answered the exact same way. But what was really great is he said, well, I checked this all out online. And I was waiting to hear, like, oh my gosh, what is he gonna say? Okay, because this doesn't happen very often. I talk to a patient. And he said, you guys are awesome. He said, the science is there. Everything that I learned in your office that you trained in is true. And he said, I'm gonna do it. I wanna be healthy, and I get it. So it's been around. Your patients, if you haven't implemented this into your protocols and your conversation and your patient education, and you're all on the same page across the board, you're missing out on helping your patients. That's probably most important, is your patients are missing out. Okay, that's number one. But number two, you're missing out on creating the value that we have available for your patients. And they're gonna become more dedicated to you, and they're not gonna wanna go anywhere else. So it's we now know, and these are all the different areas. If you haven't been studied up on this, please do your research. Look at it's everywhere. You can spend all kinds of time on PubMed, Google, just look for scientific articles, relationship between rheumatoid arthritis and periodontal disease. Diabetes, that one's been around forever. Alzheimer's. So just take some time, because we have literally thousands. I happen to have the honor of being on the board of the American Academy of Oral Systemic Health, and we've brought in practitioners, keynotes, Drs. Bale and Doneen. They've written an amazing book called Beat the Heart Attack Gene, and they are cardiology prevention specialists that have created a method. And their method, they will give you a guarantee that heart attack and stroke is 100% preventable. I as a health coach, I even get like, well, you have to do a lot to make sure that that's gonna happen. But do you have any idea, how many have read the book? Anybody? I know you did. Okay, so in that book, how important and how much of an emphasis do they have in their Bale-Doneen method that you know without a doubt that you do not have any dental infection? This is not just about periodontal disease, it's infection. How important is that to Bale and Doneen? Significant. I went to their preceptorship, we happened to talk, and they showed a lot of cases, didn't they, with radiographs of patients. One of them was actually an associate in her practice that wanted to become in their Bale-Doneen method, and he went through testing. He had biomarkers that showed he had an infection. They didn't know where, okay, when you get your blood test, And as it turned out, he had a heart attack and he died. He was a young physician in his 40s. And they showed the radiographs of the dental infection, didn't they? You saw that. So it's there, and we need to make sure that we're integrating that in there. So for those of you that haven't really done the diligence on this, you know, we could spend a whole day on really looking at the pathogens and looking at the very, very specific. I always tease the team when I get to go in and train with them. It's like we're going back to microbiology. We're going back to physiology. We have to understand the chemistry. We have to understand how bacteria and pathogens initiate the inflammatory response. That's where the causal relationship clicks in. It's not just bacteremia where the bacteria is going to move through the bloodstream, but it's that low-grade chronic infection. What percentage of your patients have a low-grade chronic infection? Any confessions here? Probably quite a few of them. And some of them we're frustrated with. We know they do. We know they're going to come in that door and they left with bleeding. We know they did. And when I get to work with a hygienist, they know that too. And they're frustrated because they thought, you know, they've tried everything. But as soon as we start really refining the protocols, they're going to see a change in that. So some of the action plan for implementation, your checklist, it starts with a diagnosis. This one is so easy, isn't it? Health or disease? Thank you. I got some action here. Okay, that is a no-brainer. Okay, but seriously, this actually, the lower looked the same way after scaling. Okay, so your whole diagnostic picture needs to change, but also the biggest problem with this patient is they didn't have hardly any attachment loss. It was really 3mm pockets, hardly any bleeding on probing, but generalized moderate to heavy bleeding on provocation. And so your treatment plans need to expand to a whole nother level. So when you say, you know, there were some people that I still see sitting here, how do I get my hygienist to do this? You know, how do I get they need to understand the difference between scaling and root planing, calculus removal, and biofilm disruption, full mouth bacterial disinfection. There's a difference, okay? Whether your hygienist was out of school last year or your hygienist graduated 20 years ago or more, our boards were based in what? Okay, to pass a board, what do we have to be really good at? And that's still today. Pardon? Calculus removal. And we are trained technicians. And you better believe we're pretty proud of it. And we're put on the earth to remove this calculus, right? But guess what? The world has changed. And the biggest paradigm shift that we haven't gotten into the academic world yet, believe it or not, they talk about biofilm, they talk about it, but we haven't changed the protocols to actually treat biofilm disease. That's where the challenge is. So when you're frustrated with your hygienist because they're not doing everything or they're not fitting into that model, they need to see it differently. They need to understand the pathogenic load, and they need to understand what to do after calculus is removed. Because I'll guarantee you, when a lot of your patients are coming in, the biofilm invasion, you know, they're a very sophisticated network of well-organized microbes. So this one you've probably seen, you've read, your hygienists have read it, big deal. But what does it mean? It means they are sophisticated and they're tricky. And you have a microscope. So you get to see them moving around, right? I have videos that I spared you guys, okay? But when we go in and we go training, I have videos. I have videos of path of bacteria moving, and it is live. We have bacteria, literally, some of you have seen it, right? Where the actual macrophages, the white blood cells, are literally engulfing. We have videos where the white blood cells couldn't do their job because the bacteria was so overloaded, and it literally turned around and stopped the healing process. It stopped. So we have to understand biofilm, and you have to shift your protocols because they're very sophisticated, very complicated. And there's a difference when we're using our hand scalers and our ultrasonics. We're using them different now. Okay, we're using them different. It's not the way that we were all trained. And so your hygienists need to get the update on that. They need to get excited about it. Just like some of the materials, the procedures that you all learned in dental school, even a year ago, 2 years ago, 5 years ago, you're not using the same materials, are you? No, some of the techniques are different, the instrumentations, the technologies. So all of that, so you have to have treatment plans that are based in biofilm disruption. Literally, the biofilm burrows. It not only burrows, it translocates. And what that means is when we actually remove veneers of calculus, we have some pretty smart pathogens, and they move. And where do they go? They go deeper. They not only go deeper, they embed into the tissue. So if we need to have protocols that understand that, and hygienists that understand that. So when we treat an area, 2 weeks later, we treat a new area, we're always gonna have to retreat and find out where that, there may not be calculus left there, but if there's calculus, we're certainly gonna remove that. But we have to chase the biofilm. And we have to know the bacterial load. And so we're doing a lot of things with saliva testing. So how do we overcome these obstacles and barriers? You know, it's all about education. It's about keeping your hygienists excited, empowered, about learning, wanting to do more. Look at all of you. You're here on a full weekend learning. You've been totally buried into learning how to become better at what you're doing in your business. And that's what your hygienists need to be willing to do and to go home and apply it. So there's so much science and research on oral systemic health. It's literally become our legal and ethical responsibility. First lawsuit, checking my time here, first lawsuit due to that. I'm just gonna tell you about that. Maybe some of you have heard it. And then we can go through these rather quickly because it starts in California, right? And so I heard this from a client. I don't know where our attorney went, if he's still in the room, but what happened is, it wasn't a client, fortunately, but we heard it from a client, that they diagnosed this practice in Southern California, diagnosed periodontal disease on a patient. The patient refused treatment, they documented it. Cool, right? It was documented. The patient relocated to Northern California, had a heart attack, and guess what the cardiologist told them? That there was a causal relationship. Okay, now, it's a new world, isn't it? Because we still do, and I'm gonna admit it, we still have some of the cardiologist world, or physician world, they don't get it. But we have the science now, and the research is solid. So we now have become, our liabilities changed, our legal responsibility. So what happened is this patient said, wait a minute, you mean, if I have some kind of infection in my mouth that might relate to my heart attack? And the cardiologist said, yes, you need to find a good dentist that's going to guarantee that you don't have any infection in your mouth, whether it's a dental infection, decay that's not treated, and or periodontal infection. He said, well, I did get periodontal diagnosis. They told me I needed treatment, and I got busy because I moved. And he said, but guess what? They didn't tell me what. What didn't they tell him? That there was a relationship. And then fortunately, they went to arbitration instead of court. But the mistake that the doctor made in arbitration is they said he didn't have any medical history of heart disease. He had no medical history. So what percentage of our patients, or all of us, and our family, and our friends, what percentage of us know that we have heart disease? Probably about 50% of people that have heart disease know they have heart disease. So the first time they find out they have a heart disease is when they have an event. That's scary. So our obligation, our legal and ethical obligation has changed. And when we have a patient in the chair, there was always one of those patients that's like, no, I don't want to hear about it. You know, I come in every 6 months, that's it, forget about it. You know, we have some of those. We have to have them understand. And there's a way to have them understand. So a lot of it has to do with time management, it has to do with case presentation, it has to do with verbal skills. And so these are the screens. I know you saw a good video the other day, but these are the different screenings now that are our legal responsibility. The one that's changing is our screening for airway. This is your hygienist. Okay, legally, we have to work with all of these. Dr. Evangelista and Tina, they briefly talked about the critical aspects of proxemics or body language, sitting down. If you see your hygienist educating your patients while they're laying down, don't yell at them because they need training. Because you can't yell at your hygienist, they'll get upset and they'll cry, right? Yeah. Or they'll get mad. So you can't just you can't pick at them and go, well, don't do that anymore. You got to do this. You know, we can't do those things. But proxemics, eye to eye, knee to knee, sitting down, chair side, they have to know we're authentic. And it has to be a systematic, structured approach. So the same system that you probably are doing better with your new patients, because a lot of times we take some thought to that. We're mindful, right? We know we're supposed to collect data, comprehensive information, and then sit the patient up, pull our mask down, and talk about it, right? So it's logical. So those are things that you don't want to skip. That's what we do in our training. And probably even the most important thing is the doctor hygiene exam that you saw yesterday was probably an abbreviated one because I already know the patient in the chair didn't have a lot going on, right? But your hygienist should be, you know, the typical doctor hygiene exam traditionally. When you go back on Monday or Tuesday, for those of you that are still seeing patients, pay attention. And when you say, so how did Joe look today? Or what's going on with Joe, right? We have some hygienists that will tell you more than you want to know, and then you have some that don't even tell you even close to what you want to know. Okay, so we need a systematic, structured approach that they give you exactly what you need to know, and that they have collected comprehensive data, and they literally do a review. I updated all of the screenings as you asked, Dr. Smith, and that would be, so Joe doesn't have any concerns when he came in, but I did update his medical history as well as his family history. His family history is diabetes and rheumatoid arthritis, so I did discuss with Joe the relationship between the health of the mouth and how that does affect the body, and we did talk about that. Also, I updated his blood pressure was 120/85, head and neck cancer screening, negative findings. His restorative screening, you can see the images of all of the intraoral photos that I took, and I've already discussed the pending treatment that we have documented from the last time. That today, however, he has agreed to going ahead and scheduling for that. He realizes the relationship between the infection in his mouth, periodontally, on those two teeth on the upper left is also causing the infection, contributing to the disease as well. So he's ready. So the actual periodontal screening findings were generalized 3 and 4 millimeter pockets, several 5s, and actually one localized 6 millimeter pocket. So he's eager to go ahead and get this treated. He recognizes even the relationship between the family history. Fortunately, he doesn't have a medical history that he knows of, but we did discuss that. So that's all handed to you, doctors. So what you have to do is sit down and make the diagnosis, confirm it, and make sure the patient knows that you're looking at these things as well. So we already, there's different technologies. I'm not gonna run any more over than you've already stayed a long day to learn about the different technologies. Probably the one that I'm the most passionate about, that's created the biggest shift in my world. We use lasers, we use subgingival air polish, and there's so many amazing technologies, but we're now moving into a whole oral inflammatory load era in our world. We have to know the pathogens. And we've been doing saliva testing now for over 12 years. And I'm gonna tell you, I probably didn't have my biggest paradigm shift until about a year ago. And it was when we actually did a saliva test. A hygienist was diagnosed with diabetes. She had her teeth cleaned by her hygiene friend. Okay, she didn't have any bleeding on probing, and she didn't have any pockets above 4 millimeters. So what she decided is she had read up, she was studied, she had looked there, she'd been doing her homework. And she understood we have a critical bi-directional relationship with diabetes and periodontal disease, and she knew that clearly from her training. And so she got nervous. She sent away for her own saliva test, and it came back. She had literally 11 pathogens above, 3 of them were above threshold. And this was a woman that was a hygienist that took care of her mouth. Amazing. No plaque. And she didn't have any bleeding on probing. So now this becomes confusing, doesn't it? So the bottom line is, once we looked at her mouth, she didn't have any bleeding on probing, but she had light bleeding on provocation underneath every single crown that she had. So her treatment plan didn't become extremely complex or comprehensive, but it had to be done. Because the bacteria in these biofilms burrow and they hide. And if we're doing these quick run-by types of cleaning with a quick polish, it's not going to be eradicated. So what happened is she had a therapeutic treatment plan, and we retested about 8 weeks later, and all the pathogens were gone except for one very low on the end of the threshold, very, very small. And that's what we want to shoot for. So that's going to be one of the things that we do. So what is this? This is Karen Davis. If you know her in Dallas, okay, she was a trainer in our company for a really long time, but this was real, okay? So we talked about that. Dr. Evangelista and Tina, they talked about the overwhelm, the stress, the time management, and all I can tell you is that without breaking out into an entire training, you know, and having you stay over, it can be done. And if it can be done, and we've done it in thousands and thousands of practices, where a hygienist will literally, and you know our hygienist, and I'm a hygienist, we can talk about us, okay? How many times have you gone to some type of seminar, you came back and you said, hey, we're gonna do this. Isn't that exciting? And they go, oh, wait a minute, where are we supposed to fit that in? Right? Where are we supposed to fit it in? So all I can assure you is the secret to fitting it all in is fitting it all in. It starts with the right diagnosis. Okay, because if we as myself as a hygienist, I put any single one of you in my chair and I screened you and there was disease, I'm not going to try to clean your teeth. But I am going to give you a treatment because I want to make you happy. And I'm going to polish your teeth, and I'm going to educate, and I'm going to communicate, and I'm going to do an initial therapy that's going to begin to address the infection so that you understand you have an infection, and the treatment today is not going to treat that infection. And you will have to come back in order to get this treatment. And patients get it, they love it, they want to know the truth, and they want to know what can be done about it. And once you figure this out and it goes into the time wheel, I promise the hygienists that have literally, I want to say, broke through this, the pressure's off of them. So, anyway, that is all at this point. So I know Dr. Evangelista probably has some wrapping up. You have some wrapping up?
Yeah, well, I think probably both of us. Dr. E?
And, but while we're waiting for him to come over, so what questions do you have about hygiene?
Speak the real truth.
Well, we use, biofilm is a very sophisticated colony of bacteria that does not easily get disrupted. The only way it can be disrupted is mechanical, but if it's not thoroughly, it builds in layers. So we use laser, but we also use a repetitive application of our ultrasonics and a lot of flushing and a lot of irrigation, and some manipulants as well. But a lot of it is how much time you spend in the area of treatment, depending, because biofilm builds in layers. And it's underneath the calculus. So if you've removed the calculus and you've planed it nice and smooth, but they're still bleeding, you've got a problem still. And so we have to treat it to the point where there isn't any bleeding.
You have protocols and fee schedules?
Yeah, protocols and fee schedules and all of that. I don't know that, you're gonna talk to them about all that, right? Okay, and how they can get all that? Cause,
I'll say it after.
okay, thank you.
Thank you so much. Just a couple quick notes for Dr. E. First of all, you guys are amazing. Great work. So DEO folks, there's a survey. You know how much we love these surveys. We really appreciate you filling those out. So I'm looking at you. You guys already filled it out. Chris, all right. So DEO folks, fill out that survey. Let us know your feedback. We really appreciate that. I just want to say on behalf of myself and the DEO folks, we appreciate the relationship, Dr. E. You've been amazing. This has been truly beneficial. I don't know about you all, but I don't think anything like this in dentistry exists. You've truly kind of birthed something that's brand new. You've innovated, really, and you know, we fully support your mission to kind of disrupt what's going on here. So, before you say yours, I want to give Dr. E a round of applause. Thank you.
All right, thank you everyone for coming and supporting this. Definitely, we'll be emailing you, but if you want to email me directly, my email is dre@dentalforce.com, which is dr.e@dentalforce.com. My cell phone number is 510-919-2436. You can call, text me at any time, but definitely we're going to be reaching out to you anyway. If you still have any questions or anything, I think most of my staff is still here. I don't know. They're waving in the back, so I know they're still here. They're probably not leaving because they know I'll be upset if they did leave. Other than that, you know, I really appreciate all of it. On a scale of 1 to 10, how did I do? All right. Who wants to spin the wheel? All right. Yep. So, do we still have a camera set up in the back or no?
No.
No. Okay. Well, we'll reach out to you to do some testimonials too one of these days. But
Do you have a care to share card?
care to share cards will be given to you before you leave. But thank you.
All right.